Assalamu alaikum. Good morning. It's really my pleasure to be here today with you in this fruitful meeting, and thank you for Dr. Abed and all the scientific and the organization committee. Let me introduce our last but not least speaker, Dr. Moamen Gabr. Dr. Moamen Gabr is our eminent star, and he's a fellow of the American Society of Gastrointestinal Endoscopy and also director of the Advanced Interventional Endoscopy Fellowship Program at University of Cincinnati, USA. And he is also expert in the third space procedures and ERCP, also an eminent lecturer in different international conferences. And Dr. Moamen today, he will give us a talk about the management of the benign biliary stricture. The floor is yours, Dr. Moamen. Thank you.
Thank you, shukran. First, I would like to start by thanking the course organizers for the kind invitation, especially my brothers, Dr. Abed al-Lahabi and Dr. Saad al-Rajhi. It's always a pleasure to be here in the beautiful city of Riyadh, and excited to be with you all today. Here we go. This is my home base, the UC Medical Center. It's where I am fortunate to practice with an amazing team. These are my disclosures. And these are our learning objectives today. To cover these objectives, we will start by a brief talk about definition and etiology of benign biliary strictures. Then we will discuss in detail the two most common etiologies of benign biliary strictures, which are iatrogenic and inflammatory strictures. When it comes to definition, benign biliary strictures are basically narrowing of the bile duct that ensues from diverse etiologies, triggering local inflammatory responses and ischemic insults that effectuate secondary fibrosis and scarring that manifests as cholestasis after ruling out malignancy. And it's very important to rule out malignancy before we make the diagnosis of a benign biliary stricture, since many of those would mimic malignancy in some sort or may hide a malignancy. The causes of benign biliary strictures are broad, as you can see, but can be summarized into two main categories, each with one main pathologic process. That's iatrogenic, where post-cholecystectomy and post-liver transplant strictures being the most common etiologies, and chronic inflammation with chronic pancreatitis being the main pathologic process. Diagnosis and management are generally the same for different etiologies, with few niche differences that we will highlight at the end of the talk. Benign biliary strictures can be clinically challenging, since diagnosis can only be made after excluding malignancy. That can be a complex and lengthy process that requires multiple and repeat procedures, and sometimes to sample that strictured area. Another challenge is that some of the patients who have benign biliary strictures are high-risk patients, whether it's for ERCP complications or for the risks of complications from biliary obstructions. And above all, we do not have really solid guidelines when it comes to management of these strictures, as we will show later. From here, the rest of my talk is based on two stories about two of my patients with benign biliary strictures, and we'll use this to highlight how do we diagnose and manage those strictures. Our first story is about Mr. X, who is a 42-year-old male with history of alcohol-related cirrhosis. I met him for the first time after he received his liver transplant. And as you can see from the picture, he was so excited after he received his new liver. But this joy, unfortunately, was really very short-lasting. After he was discharged from the hospital, he went home, and a few weeks later, he wakes up in the morning with his wife staring at his eyes. Mr. X's wife told him that his eyes and skin color look really yellow, like a lemon, or a ripe yellow mango if you are a mango fan like me. And the couple call his transplant coordinator, who advises them to come to the ER. So they come to the ED, and in the ER, the patient is jaundice, and his labs show a total bilirubin of 6, alkaline phosphatase of 525, ALT and AST are elevated, and a right upper quadrant ultrasound shows new onset intrahepatic biliary dilation. So at this point, our interventional fellow gets consulted, and he goes, evaluates the patient, and the first thing that comes to his mind, what should be the next step? Should we move to getting a CT of the abdomen with contrast, or do a liver Doppler, or get an MRCP, or proceed directly to ERCP? This is the current algorithm for management of post-liver transplant suspected biliary obstruction, and that's in general how the decision tree works. But at our practice, we've added those 2 questions in the red box to the left. And I always ask these couple of questions to the fellow before we do the procedure. Does the blood work suggest an obstructive pattern of the liver workup? And does the patient have a native papilla or not? Because if they already had an ERCP, doing another ERCP is really much higher risk compared to cannulation of a native papilla. And remember that in our ERCP world, an interventional endoscopy, we consider ERCP one of the high-risk procedures, but if we look from the transplant eye, it's one of the lower-risk interventions that can be done to manage post-transplant complications, where some of them can be really very invasive to take care of. With the new biliary dilation on the right upper quadrant ultrasound and the labs suggesting this obstructive pattern, we proceeded with ERCP. And as you can see on the cholangiogram shows a short, single stricture located at the site of the biliary anastomosis, which is consistent with an anastomotic stricture. We dilate the stricture by a 4 millimeter by 4 centimeter dilation balloon, and then we place 2 side-by-side plastic stents across the stricture into the intrahepatic ducts. After overnight observation, our friend goes home, he's feeling good, his total bilirubin next morning is down from 6 to 2, and he's feeling well. But after he goes home, he was supposed to come back in 2 months, but after 5 weeks, his wife notices the same findings again. He's having jaundice. They talk to the transplant coordinator, and they advise him to come back to the hospital. When he comes back to the hospital, labs show rising bilirubin and rising alkaline phosphatase consistent with recurrent biliary obstruction. Patient is taken to the ERCP suite, and as we go down into D2, you can notice there's some debris in the stent, and it's basically partially occluded. So the stents are removed, and the bile duct is cannulated again, and the cholangiogram is showing persistent anastomotic stricture and really very limited improvement in the intrahepatic biliary ductal dilation. So this time we dilate up to 6 millimeters with the dilation balloon, and we decide to put a fully covered self-expandable metal stent. And as you can see on the fluoroscopy image, you can see a waist for the stent, which means that the stricture is still there, and you can appreciate more the persistent intrahepatic biliary ductal dilation. So a few technical points when we place fully covered self-expandable metal stents into the intrahepatic ducts. It's very important to be mindful of not occluding or basically jailing one side of the liver if you place the fully covered stent across the biliary ductal bifurcation. And to avoid that, you can simply shoot an occlusion cholangiogram through the stent after stent placement to confirm filling of both sides. And one of the other options that can be used if you're in doubt or if the stricture is really high up and close to the bifurcation is to use partially covered metal stents. And in the US, we do have these viable stents that come with side holes on the proximal 2 centimeter of the stent. So even if the stent crosses the bifurcation, if it's within 2 centimeter, that does not completely occlude the side of the liver where the stent is passing across. This time, Mr. X goes home, and we don't hear back from him until his follow-up ERCP that was scheduled in 4 months. He comes back in 4 months for the follow-up ERCP, and you can see on the scout film that the fully covered self-expandable metal stent now has expanded to its full size. There is no waste, and the most beautiful part of that scout film is the air cholangiogram that you can see in the bile duct, and I really love to see those air cholangiograms. Once we take the stent out and we inject a cholangiogram, you can see that the stricture has resolved, and the intrahepatic biliary ductal dilation as well has markedly improved when you compare it to the previous ERCP. So post-transplant strictures are defined as single, short strictures within 5 to 10 millimeters of the biliary anastomotic site. And on cholangiogram, you can see it as a narrowing at the anastomotic site. The overall incidence is about 13% in patients status post-liver transplant, and it accounts for 40% of biliary adverse events after liver transplant. The majority of these strictures occur within 2 to 12 months after liver transplant, but they can occur at any time. Early onset strictures are often related to technical problems during surgery, while non-early strictures are mainly related due to either vascular insufficiency, ischemia, or problems with healing and fibrosis. As we showed with our case, ERCP therapy is the first-line management approach for biliary anastomotic strictures, and that's also according to the Asian Pacific Consensus Guidelines. And the earlier the intervention, the better the response. Multiple plastic stents are an acceptable option, and they will be exchanged every 3 to 4 months for up to a total of 1 year. The other option is to use fully covered self-expandable metal stents that can sit longer for up to 6 months. That brings a good question when we compare those multiple plastic stents to the fully covered self-expandable metal stents with regards the amount of dilation for the biliary stricture. So how many times greater would a 10 millimeter fully covered self-expandable metal stent expand the stricture when compared to a 10 French or basically 3.3 millimeter plastic stent? For those of you who think it's 3 times, would you please raise your hand? Who thinks it's 3 times? Okay. And who thinks it would be 5 times more? Okay. How about 7 times? All right. So my initial impression was actually 3 times in the beginning, but the answer is 7 times more. And this has to do with the cross-sectional area comparison. So the area of the circle is calculated by multiplying the square of the radius by a constant which is called pi. And for a 10 French stent, the radius is 5. And when you multiply that with the constant, you get a surface area of 78 millimeters square. When you do that for a 3.3 millimeter stent, it's 9 millimeters square. So the surface area is more than 7 times of a plastic stent. But despite this impressive difference in the surface area and the diameter, a meta-analysis comparing both options did not show really any significant difference in the response, except for the duration where the stent can sit in from 3 months when it's multiple plastic stents to 6 months with the fully covered self-expandable metal stents. So that was our first story. Our second story today is about EUS-guided rendezvous for a benign biliary stricture. And since it's Valentine's Day, there is no better day to present a case of rendezvous. So that's why I picked this one.
2 minutes left, Dr. Gabr. 2 minutes left.
I'll try to go faster for this one then. So it's about Miss E. She is a 35-year-old female with history of familial hypertriglyceridemia and chronic pancreatitis. And she presents to our hospital with new onset of jaundice for the last couple of weeks with nausea and vomiting. Her labs are consistent with biliary obstruction, and her MRCP shows distal bile duct stricture. So we decide to proceed and do an ERCP for her, but given the symptoms of nausea and vomiting, we decided to start with an EGD, which showed some narrowing at the duodenal sweep. So the EGD scope can pass, but the ERCP scope would not. So we decided to do balloon dilation for the duodenum up to 18 millimeter to allow for the ERCP scope to go. I'm trying to kind of go faster here so that they wouldn't cut me off. So we go down with the ERCP scope. You can see the duodenum is still narrow there, and it's really very hard to find the ampulla. After trying, you can see the ampulla on the upper right corner of the screen, and it's very hard to get an ideal location to cannulate. So we try multiple times. We can only get pancreatic duct cannulation, and at this point we place a pancreatic duct stent, try for multiple more times with no success in getting into the bile duct, again because of this tight duodenal lumen. So we decide to switch to EUS-guided drainage, and on EUS you can visualize the dilated intrahepatic ducts. And using a 19-gauge needle, we inject contrast. We're able to get a cholangiogram that shows marked dilation of the intrahepatic and the proximal bile duct with almost complete cut off when it comes to the end of the bile duct. We're able to get a wire across, and then the wire is coiled in the duodenum. And once you do that, you have one of two options. You can either do an EUS-guided hepaticogastrostomy or switch to EUS-guided rendezvous. And whenever we think the etiology is benign, we typically lean more towards respecting the anatomy. So in that case, we decided to go with a rendezvous. So the EUS scope is removed. You switch that for an ERCP scope, go down in the duodenum, and you can see the guide wire coiled into the duodenum. And at this point too, you also have two options. You can either cannulate next to the guide wire that's coming out of the ampulla, or you can grab the guide wire and backload a sphincterotome into the bile duct. Once you do that step, you already have an ERCP cannulation, and on the cholangiogram, you can see there is the intrapancreatic portion of the bile duct has a tight stricture there. And we'll come to that later if we have time, but basically any stricture in a patient with chronic pancreatitis, you should rule out malignancy. So we do biliary brushings, and after the brushings, we decide to place a fully covered self-expandable metal stent, especially in this case because you don't want to repeat ERCP soon given the duodenal stricture. Distal bile duct strictures in chronic pancreatitis develop secondary to scarring and fibrosis from recurrent and chronic inflammation. As I mentioned, it's very important to exclude malignancy in patients with chronic pancreatitis because in the first couple of years of diagnosis, they are at a 16-fold increased risk of malignancy. ERCP with a stent insertion is the preferred treatment for benign biliary strictures due to chronic pancreatitis. This slide is one of the most important slides and loaded slides on the presentation, and briefly it's comparing all the stenting options in those patients from a single plastic stent to multiple plastic stents to fully covered stent and biodegradable stents. The summary of the slide is basically single plastic stent is not durable, it's not a good drainage option. Your best options are multiple plastic stents and fully covered self-expandable metal stents. Again, fully covered metal stents are more durable. So fully covered stent placement over multiple plastic has similar efficacy and safety, but it's more durable option. The Asian Pacific Consensus also mentioned a percutaneous rendezvous technique, which can be done with EUS if you fail cannulation or if the ampulla is not accessible. We'll skip the other niche areas like PSC, again for the sake of time. And my take-home message today is biliary stricture evaluation needs to be a multidisciplinary teamwork. Understanding the etiology and ruling out malignancy is essential before deciding on the optimal treatment plan. Non-invasive imaging is essential to help with planning for the procedure. And our management goals in benign biliary strictures is to resolve bile duct obstruction and achieve long-term ductal patency to maintain liver function. For that, you can use a combination of endoscopic stricture dilation and biliary stenting, whether it's multiple plastic stents or fully covered self-expandable metal stents. And again, it's always a pleasure to be here. And